here at the National Hemophilia Foundation. Today's webinar is on the impact of Emicizumab on monitoring assays. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. If you are viewing this webinar on one of our social media platforms, you can go ahead and ask your question in the comment section. We have NHF staff members monitoring these questions, which we will post to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, December 9th. I am joined today by Lucy Lee. Thank you for taking the time to join us. I'll go ahead and turn it over to you to get us started.
Yep, I apologize for the delay. I could not find that unmute button.
Oh, that's okay. No worries, no worries.
All right, let me try this again.
Yeah, of course.
Thank you very much for the invitation. Let me get back to the start of this presentation here. Great. Thanks again for the invitation for us to have an opportunity to talk about the effect of Emicizumab on various coagulation assays. As mentioned, my name is Lucy Lee. I'm a medical science director at Genentech. I am presenting this talk this morning on behalf of a colleague who also kindly shared her slides with me. So I'll do my best to do these slides justice. This is a mandatory disclaimer slide for us. Not all of this content is applicable necessarily in this talk, as Emicizumab is approved in the US. Just a quick background, Emicizumab is a humanized bispecific monoclonal antibodies, and it really just replaces the cofactor activated factor VIII in mediating the 10-ACE reaction and restoring coagulation cascade. It is administered subcutaneously, and like monoclonal antibodies, it has a long half-life, in this case out to about a month. It is maintained in steady state and demonstrates steady state concentrations in plasma that we'll show later. And because it is structurally not the same as factor VIII, it is not expected to induce factor VIII inhibitors, nor is it sensitive to effects of factor VIII inhibitors, which is why it's approved for use both in patients with inhibitors as well as without inhibitors. So again, it is approved in the US for routine prophylaxis for patients with hemophilia A, aged newborn and up, with or without inhibitors. And they're after a loading dose sequence of weekly loading dose for 4 weeks, you can choose a regimen that is either weekly, every 2 weeks, or every 4 weeks. This is sort of an at-a-glance look at the Emicizumab clinical development program. It is one of the largest programs in hemophilia A to date. Many of the studies have read out results and have been published. There are a few ongoing studies, and collectively, the phase 3 clinical trials in this study are often referred to as the HAVEN program. But you can see that the overall development program includes patients with and without inhibitors and spans the age range from newborn and up. And also, it does include several women in this program, specifically out of the HAVEN 6 study. Here again is a closer look at the HAVEN 1 through 4 program, for which there have been primary analyses and publications, as well as long-term analyses. They span the range of pediatric, adolescent, and adult agents and evaluated the safety and efficacy of approved dosing regimens. And a really quick look at the efficacy data in terms of long-term analysis. You can see that the benefits in bleed reduction seen in the primary analyses of these trials have continued and have been sustained over time, over 24-week treatment intervals. And this is out to a little bit over 2 years. Similarly, the proportion of patients experiencing zero bleeds have also been sustained out to this same period of time. And importantly, we did see 95% target joint resolution in this long-term analysis, with about 90% of patients experiencing no spontaneous or traumatic bleeds into the target joint while on Emicizumab prophylaxis. Looking at the clinically efficacious concentrations of emicizumab, you can see across the various dosing regimen that there is a very steady and sustained trough concentration seen here. The average concentration on a weekly maintenance regimen is roughly about 50 micrograms per ml, and the typical therapeutic range observed in patient populations anywhere from 25 to about 80. And you can see based on the established efficacy as well as this very persistent concentration level and also the half-life, because the half-life essentially means that there's little peak and trough variations around these means that this is a drug that does not require monitoring routinely. And in fact, the MASAC recommendation on prophylaxis does include the consideration of emicizumab for prophylaxis, both in the primary and secondary prophylaxis setting, and that routine monitoring is not recommended. So talking a little bit about differences between emicizumab and factor VIII, because this is a question that comes up quite a bit. You can see on the left that emicizumab structurally does not look like factor VIII. It does mediate the same cofactor activity as activated factor VIII in the Timmins reaction. And in the absence of binding to activated factor IX, emicizumab is not active in circulation, so it doesn't have any impact on other parts of the coagulation system. On the right, you see essentially a summary of factors that affect in vitro assays and sort of where the differences are between factor VIII, activated factor VIII, and emicizumab. I think a key important note to be aware of is thrombin-induced activation of factor VIII is a critical step in forming a clot, and this is a time-dependent process, and this time is accounted for in the normal values of coagulation tests that are clotting time-based. And because emicizumab is not factor VIII, activated factor VIII, and does not require activation, it does not exhibit this lag time. And we'll talk a little bit more about this in the slides a little bit later in this hour. We already talked about the differences in half-life that enables longer time dosing for emicizumab, and it's important to also note that emicizumab exhibits different binding kinetics compared to activated factor VIII. Activated factor VIII actually binds with greater affinity to 9A than emicizumab does. And emicizumab binding is species specific in that it will recognize human proteins, but not bovine proteins. All right. And this is just a summary of what we have already talked about, that it binds with lower affinity compared to activated VIII. It doesn't require activation. It's insensitive to the effects of factor VIII inhibitors, the long half-life, and the fact that its action is actually very specific and other checkpoints in the coagulation is unaffected. All right, a little bit on the topic of assay variability in general. We actually do know this is not a new topic. In terms of looking at one-stage clotting assays, evaluating factor VIII or factor IX activities, there's a good amount of variability based on the type of reagents that's used, as well as the type of the product that we are looking at. This variability is somewhat addressed with the use of chromogenic assays, but not fully eliminated. In the setting of gene therapy, we do still see discrepant one-stage and chromogenic factor levels, with one-stage factor VIII activity level reading out about 1.6-fold higher than the chromogenic activity. And focusing a bit more on emicizumab effect on assays. This is basically a table out of the emicizumab prescribing information. The brand name for emicizumab is Hemlibra, and you can see on the left is a listing of assays that are affected by Hemlibra, and on the right, a listing of assays that are not affected by Hemlibra. I think the key thing to take away from this table is that Hemlibra affects assays that are based on intrinsic pathway clotting time-based assays. So meaning this will affect all APTT-based assays, and And we will spend some time a little bit later in the talk talking about what that means in terms of monitoring patients. And all the assays on the right are basically using measurement principles that are not clotting time based, generally chromogenic or immunologic methods. This is a slide that is actually in the concluding part of this talk, but I thought it worthwhile to bring forward because where there is known and substantial assay interference, it's probably also worthwhile to talk about what can be used. So across the board, we do understand that APTT-based assays are affected. And so one-stage factor VIII activity assay is not an appropriate measurement. And then if someone wanted to measure factor VIII activity, the best thing to do is to use a bovine-based chromogenic factor VIII activity assay. And we spent some time talking about why emicizumab does not require routine monitoring, but it does not mean that it can't be quantified. And we'll spend some time a little bit later talking about how that is done. Essentially, that's done through the use of a modified one-stage assay with a product-specific calibrator. And for patients on emicizumab for whom you want to assess factor VIII inhibitor levels, the best way to do that is through the use of a bovine chromogenic Bethesda assay. We were asked to talk about this paper specifically that came out in 2019 in thrombosis and hemostasis around the effects and interference of emicizumab across a broad range of coagulation assays. All of the authors here, including the primary author, Joanne Adamkiewicz, I practice saying that name, are Genentech authors. And this article, as well as its supplementary material, are available for open access. So what was done in this study? There's a lot of text here, but just to summarize, a variety of assays were evaluated across a broad range of emicizumab concentration. And generally, they looked at assays that used triggers at different parts of the coagulation cascade, or used assays that had different principles of measurement, whether they be clot-based or chromogenic or immunologic. And these assays were done in the presence and absence of emicizumab to understand what type of assay interference, if at all, is observed. So I'm going to show you in the next several slides the list of assays that were performed in the study. It's quite extensive, but not fully comprehensive. So I think the key things to note from this is just the type of assays that are being done that you'll see in the left-hand column of these tables, and the type of assays they are, whether they're clot-based or not, and additional details. We won't spend any time talking about them in the interest of time. All right. So moving on to results, it's worthwhile taking a little bit of time talking about differences in 10A generation kinetics between activated 8 and emicizumab. And we did talk about this at a high level, but this is just more pictorially represented. You can see that thrombin-induced conversion of factor VIII to activated factor VIII is an important step. And this is a time-dependent step and incorporated into the value of APTT. And so this is why any effects on APTT and APTT-based assays will give you essentially an inaccurate result when in the presence of emicizumab. On the right, emicizumab does not look like factor VIII, so and it does not require an activation step, so we can move forward to bind activated 9 and mediate the 10A reaction. So what that looks like in terms of impact on APTT is a very rapid and dramatic normalization of APTT values, not just within the therapeutic ranges of emicizumab that we see of 25 to 80, but also into the subtherapeutic ranges. So you can get normalization, but it doesn't mean somebody is therapeutic. on emicizumab in the way of emicizumab concentration. I think that's the first thing that's important to note. And also then subsequently downstream from this, all APTT-based assays are affected in the presence of emicizumab. On the right, what you see is emicizumab effect on thrombin time. And you can see that this is emicizumab exhibits no interference on thrombin time, meaning that it is not, it doesn't exert an impact on things that are in the common pathway. While anticoagulation of patients on emicizumab is not a common occurrence, the effect of emicizumab on INR was evaluated. And here the results are a bit more nuanced. You do see a concentration-dependent increase across the broad range of emicizumab, and within the therapeutic range that we typically see in a clinical setting, this change in INR translates into a change of 0.01 to 0.05. And so the author conclusion is that this is thought to be clinically not significant. Spending a bit of time now talking about the effect of emicizumab on factor VIII assays. On the left, you see the impact of emicizumab on the one-stage factor assay, and then it demonstrates a concentration-dependent increase. And this is a direct result of the APTT shortening that we talked about earlier. The one-stage assay uses all of the APTT reagents, and so would be affected. In the therapeutic concentration ranges of emicizumab of 25 to 80, what this translates into is a factor VIII activity that is in excess of 150%. On the right, you can see the effects of emicizumab on two types of chromogenic factor VIII assays. In the light blue is the effect on using a bovine chromogenic factor VIII assay, indicating that emicizumab exerts no impact on that assay because it does not bind to bovine proteins. And then in the darker blue, there is a concentration-dependent increase of factor VIII activity. And I want to just kind of pause here for a bit and talk about this, because in the concentration ranges that we see clinically, this translates into, on this graph, factor VIII activity that is somewhere around 20 to 50%. And this is not factor VIII equivalence, because the human chromogenic factor VIII assay is sensitive not only to the effects of emicizumab, but also any other factor VIII that's in the sample. And additionally, because emicizumab and factor VIII are distinct molecules and have different binding kinetics across these concentration ranges, they're not going to behave and interact in the assay in the same way. So having said that, though, if you got serial measurements using the human chromogenic factor VIII, it can give you some sense of directional change in procoagulant activity or even emicizumab concentration, but they should not be taken to be a precise reflection in the way of equivalence. So emicizumab, a drug that doesn't need to be measured, but can be measured. And a number of papers have evaluated this. Essentially, they show that these measurements are possible, but requires the use of a product-specific calculator and using a modified one-stage assay. And what a modified one-stage assay is basically a traditional factor VIII assay that's operating at a higher pre-dilution. And with the use of an emicizumab calculator, what you can do then is create a standard curve that gives you, a factor VIII activity and a corresponding emicizumab concentration. So it allows you to essentially read your results and do a unit conversion to micrograms per ml of emicizumab level. And the emicizumab calibrator is available. I'm just going to note that you can see my presentation. I'm hoping that you're able to see it before this. Let me find my train of thought here. Oh, yes. So the Emicizumab calibrator is CE marked, but not FDA cleared in the US. So it is available for research use only. And I believe we were asked to talk a little bit more at length about the use of Emicizumab calculator to measure Emicizumab in Australia. So this is a paper that came out this year, looking at Emicizumab, quantification of Emicizumab, both at a single reference lab using spiked samples of Emicizumab across a range of concentrations, as well as patient samples, and then comparing these results to the results from 13 different field laboratories that were all HTC affiliated in Australia. And in Australia, Emicizumab is approved for use in a moderate and severe patient population, whereas in the US, the approval is without regard to severity of disease. And again, this is the methods here, but I think the key takeaway is that multiple one-stage assay and the human chromogenic assay were used in this study, and the samples included drug concentrations within what we know to be the therapeutic range. And there was a use of a modified one-stage assay and the Emicizumab calibrator to determine and quantify Emicizumab level. And essentially, there was good recovery of these levels, both at the central lab as well as from the field labs, and good correlation. I'll just put up this slide really quickly. Just, I think pictorially, it tells you that, you know, the quantification is very consistent across APTT reagents in analyzers, and these are data from the 13 field labs. Yeah. So in essence, the conclusion from the study was that Emicizumab can be measured using modified one-stage assay and using a variety of APTT reagents and analyzers, and that there was good precision and accuracy and really low coefficient of variation, generally around less than 10% across most of the concentrations evaluated. This is just repeating what I said earlier, so I'm going to skip this slide and move on to talking about the effect of Emicizumab and measurements of factor inhibitor activity. And on this slide, we show essentially Emicizumab effects on both clot-based modified Nijmegen Bethesda assay, as well as a chromogenic Bethesda assay. And this is using patient samples out of the Haven-1 study. You can see on the left, regardless of the testing principle, that either test yield results that are very concordant with each other with, you know, really good linearity. And on the right, you see pairwise comparison of the chromogenic versus clot-based testing samples, both in the pre-Emicizumab setting as well as in the post-Emicizumab setting. So the open circles and squares show you that both tests perform very similarly in the pre-Emicizumab setting, but in the post-Emicizumab setting, what you have in the clot-based assay is a false negative readout, and this is directly the result of the shortening of APTT overexpression of factor VIII activity, leading to this negative false result. And the way you can mitigate against this is through the use of a bovine chromogenic Bethesda assay. Okay. And the rest of this talk will focus on really just a broad range of assays that were evaluated in Joanne's paper, focusing here on single factor assays in intrinsic pathway. You can see, you know, in 3 out of the 4 panels here, that increasing Emicizumab concentration will give you a 2-fold increase in factor activity levels that are measured using APTT-based assay. And that on the bottom right part of this slide, you see the use of a chromogenic factor IX activity assay will eliminate the interference effects of Emicizumab. And similarly, we see Emicizumab interference effects on APTT-based protein C and protein S assays, and within the therapeutic range of emicizumab, what this translates to is a twofold reduction in protein C and protein S activity. However, if you use a chromogenic protein C based activity assay on the upper right, you see that interference is eliminated. And on the bottom, using an immunologic based measurement of free protein S antigen, similarly avoids this interference effect. Emicizumab effect on APC resistance ratio is also exhibited because it's APTT based. And on the right, the use of a prothrombin activator based assay avoids this interference. Now, in terms of evaluating patients on emicizumab and heparin therapy, you can see on the top part of the slide that APTT, even in the presence of unfractionated heparin, will demonstrate a shortening of APTT values. And so the way to monitor patients is to essentially measure anti-10A levels, which is based on the cleavage of a chromogenic substrate, which can then be read and measured. The effects of emicizumab on single factor assays in the common extrinsic pathway is really unaffected by emicizumab across a broad range of concentrations tested. And it does demonstrate a weak effect on derived fibrinogen levels, but not on class fibrinogen level. And this has to do with the fact that the derived fibrinogen level uses a calculated approach that is based on changes in optical density in the PT-based test. And the remainder of these coagulation assays, I should just point out, are all based on non-clotting time-based assays. And so expectedly, we do not see emicizumab interference on the measurements of VWF antigen activity and on factor 13 antigen, as well as antithrombin activity, plasminogen activity, plasminogen antigen will be dominant. So how should we think about emicizumab interference on different coagulation assays? I think we think about them broadly speaking in three buckets, one where there's strong interference, one where there's no interference, and one where there's weak interference, which may not require mitigating options. And I bring back our summary slide that really summarizes what to do where you see strong interference. And so to assess for a factor VIII activity, we want to be using a bovine chromogenic assay. To assess for factor VIII activity levels, we want to be using a bovine chromogenic Bethesda assay. And this largely summarizes some of the earlier slides that we've already talked about. The strategy really is to move away from a clotting time-based assay as mitigating options, or if there are weak effects, no mitigation is required. All right, so in summary, information about laboratory testing interference is actually outlined in Hemlibra prescribing information. I also understand that most physicians don't read prescribing information, but it really is actually well articulated there. Clinicians should be aware of potential assay interference effects with emicizumab therapy and its impact on clot-based assays. Alternative testing strategies are available and should be employed. Routine monitoring is not required while on emicizumab therapy, but obviously can be measured. If there are any additional questions, feel free to reach out to us through any number of ways you like. And with that, I'll end.
Awesome. Thank you so much. So I do have a couple questions, but before we get started, I'm going to make an announcement. Recruitment is now open for Own Your Path. a program for young adult males with hemophilia who are currently in the transition years between 18 and 30. We know that maintaining adherence to a prophy regimen can have short and long-term health benefits. This program focuses on helping participants be successful by focusing on education, health coaching, skill building, and relationship building, all within an app-based environment that includes participation incentives. If you have patients in this age range and think it would be a good fit, please email us at ownyourpath@hemophilia.org and we can send you the flyer to share. For consumers, you can email us directly and we can provide more information or register you for the program. That being said, we'll go ahead and get started on some of these questions. Can you develop an inhibitor to emicizumab? Is our first one.
Yeah, so there's the potential to develop an inhibitor to any drug and certainly any monoclonal antibodies. And so the incidence of the way we think about inhibitors to drug or anti-drug antibodies is a number of different ways. One is how much occurs and how much is associated with declining levels of the drug, and how much of it is what we consider to be neutralizing, meaning it really does neutralize the effect of the drug and is also associated with increased risk for bleeding. So this is actually, we have published on this, all of our immunogenicity data, but the bottom line is truly neutralizing antibody against emicizumab occurs at an incidence of less than 1%. So it is a very rare event, but it can happen. But it's, not on the same order of magnitude that we understand for factor VIII inhibitor development in severe hemophilia A.
Awesome. Let's see. Can emicizumab be used for von Willebrand's disease?
Yeah, I think the short answer to that is maybe. So there have been a number of case reports out talking about the use of emicizumab in VWD, particularly type 3. And so I think there's potential for it to be useful in the type 2N and 3 setting, but really this is an area rich for investigation because there isn't just like one type of VWD. So it's not clear that emicizumab necessarily has a role to play across all of the different types. And so we are supporting a number of investigator-initiated studies specifically on this topic. And we hope to be able to share that data. Well, we investigators are hoping to be able to share that data. That's independent research from us.
Wonderful, thank you. Okay, I know that in comparison between emicizumab and factor VIII, I have heard that there is some concern about the impact of no factor in bone health. Is this something that is being studied, and what can you share about it?
Yeah, I mean, I think there are a lot of people interested in evaluating this, and there are a number of ways to look at this. A lot of the data that talks about the importance, for instance, of factor VIII in bone health comes from preclinical data. And so it's hard to understand whether or not that translates into humans. And osteoporosis in the hemophilia population is well recognized, but we don't just see it in patients with hemophilia A. We also see it in people with hemophilia B, where there's a deficiency in factor IX and not VIII. So I think this needs to be studied. There are a number of prospective studies going on, one of which a couple are being done by us. One in the VIII study looking at longer-term follow-up of kids where, essentially joint changes and bone biomarkers will be assessed, as well as another study called Beyond ABR. So I think what this means in human over time remains a research question that needs to be answered.
Wonderful, thank you. What are the alternative ways to test versus assays? Or assays, I'm sorry.
I'm not really sure I fully understand that question.
Okay. if you were the one that asked that question, if you're able to elaborate a little bit more, that'd be great. We can come back to that one. Let's see. For these non-factor replacement therapies, is there any worry about bone mineralization, especially in younger growing patients?
Yeah, I mean, one, I don't think anyone can truly definitively answer that, right? I mean, good bone health is dependent on so many factors. And your choice of therapies is but one of them. I think it's fair to say that good bone health, right? What contributes to good bone health in hemophilia, in patients with hemophilia, include all of the things that we know to contribute to bone health in the general population. That includes diet, exercise, vitamin D, right? And you have to strike a balance between, you really have to just find the best drug that works for you, that enables you to have what we believe to be as normal to life as anybody else. And that will, correspondingly include being able to engage in physical activities, which we all know contributes to good bone health. So I know I'm not very directly answering your question, but I hope this is helpful. It really is a much bigger context than the choice of therapy.
Great, thank you. Is there much data yet on how emicizumab performs in surgical situations?
Yeah, I mean, we think about, so there's but one small study that's evaluated emicizumab in a prospective setting. Much of what we understand of how people fare in different surgical settings comes from observations that have been made in a clinical development program, as well as in the real world setting. So across the board, for the most common, what we call minor surgeries and procedures, these are, the dental extractions and the port removals. Emicizumab seems to do well and does not require additional prophylaxis in the majority of the setting. But obviously, patients need to be individually evaluated for those. For major surgery, I think that's where, there is a need for as much data as people can share on this topic. Most of what we know are in the orthopedic setting, but there are obviously other surgeries and procedures from which we'd like to get more understanding experience. I will say that the surgery experience, at least from the clinical development program, has been fully published. So I would direct you to that for additional information.
Great, thank you. Is emicizumab a good treatment option for individuals who are physically active, like distance runners?
Yeah. So what we understand about how emicizumab works and what it renders is that it does move people from a severe phenotype to a milder phenotype. So I think maybe a way to think about this is, what is the risk, right? The benefit risk. What is the risk essentially of a mild hemophilia patient engaging in competitive sports, for example? We don't have a really good answer for you, because I think that data remains to be evaluated and reported in a rigorous way. It is one of the studies that we are funding as investigator initiated research. So, but I hope this is somewhat helpful. There are settings when I think there are desires to be able to understand and know what your factor VIII activity level is. And, there's no recipe, protocol, guidance on how to do that in the highly active setting, regardless of choice of therapy. So I think it is one that we have to evaluate more rigorously and report on.
Great, thank you. Okay, so we were able to elaborate on that one question. The alternative way to test on your last slide, that makes more sense.
Oh, yes. Okay, let me just mention a couple things. Yes, I can put up that alternate way to test on the last slide in a moment, but let me answer the question about getting access to the article. So Joanne's paper, if you simply just Google Joanne Adamkiewicz, or even Joanne Emicizumab coagulation, I think it'll come right up for you on a Google search. It is open access. So that probably is the best way to look at the slides without having to access replay, but you can also access replay and pause is I think, another option that we had thought about coming into this talk. Let me very quickly here. Oh, I cannot share screen at the moment.
Oh, let me stop. I'll stop my share and then you can go ahead and share yours.
Let's see. So this was my last slide that was shown, but I think the person might have been asking about, oops, was it this one that was being asked about? This is probably the most relevant and most commonly used assay. I can't see the chat box anymore, so you just want to give me feedback on this is what you want to take a look at in more detail.
Yeah, well, I'll give it a second to see if they are able to comment. I guess while we wait, the last slide with the third bullet is what they mentioned. Alternative testing strategies are available.
Yeah, no, that was just a very generic summary saying that where there to be drug interference effect, particularly the clot-based assays, to use different testing strategies, and at least in this case, the most common ones are shown here. Meaning, if you were interested in looking for a factor VIII activity level on somebody on emicizumab, understand that one-stage assay is going to give you this really high factor VIII activity level of greater than 150%. That is just not meaningful and not consistent with what we know to be the procoagulant effect of emicizumab. But if you did want to look for factor VIII activity of what your body makes as well as what's being infused, you can use a bovine chromogenic factor VIII assay. And then similarly to, for patients with inhibitors, if inhibitor titers, if you want to look for factor VIII inhibitor levels over time, you'll want to be using a bovine chromogenic Bethesda assay to measure that inhibitor level. So that's what alternative testing strategy means on the very last slide. Hopefully that's helpful.
Awesome. I have just a few more for you. What is the biggest drawback in using emicizumab as compared to factor replacement therapy?
I think that's really up for the patient and the provider to determine. I think patients individually have very specific needs. So, for some, right, an injection site reaction could be a drawback. For others, not having to infuse 3 times a week is a plus and not a drawback. So I think, there's no therapeutic option for any disease state that is without a need to consider how does that serve the patient's goals at this point in time, and what are the benefits and the risks of each agent. So yeah, I think it's a conversation to be had in that shared decision-making moment.
Great. And then does IVIG or gamma globin I'm sorry, mask on
IVIG.
von Willebrand's to elevate factor VIII.
Elevates factor VIII and having my worst feeling with both genetic tests help. So I think if the goal is to look at specifically the effects of factor VIII, yes, you can use a bovine chromogenic test, but that wouldn't necessarily eliminate the contribution of IVIG necessarily on the factor VIII activity level. So, and I'm not really certain that I'm the best person to ask in terms of like what that means in the way of any sort of clinical experience you may have in the way of worsening. So I do think it's worthwhile before you kind of, pick out a lab. I think it's worthwhile having a conversation with your doctor about this. I specifically don't know the influence of IVIG on factor VIII activity. So that would be something that would require some research on my part. And so I don't feel like I'm adequately answering the question here, or nor am I most qualified to answer it at this point.
Okay, well, thank you anyways. And then we have another one for you. What is the state of knowledge about using bypass agents with emicizumab?
Yeah, so that's a really good question. One, and I should point out, right, anytime you consider any drug choice, you really should just take some time to kind of look through the prescribing information if at all possible. So in the emicizumab product label, there is a boxed warning that cautions against concomitant use of emicizumab with APCC at high doses for a long duration of time. And what that essentially translates into is 100 cumulative dose of 100 units per kilo for more than 24 hours. That's where in the clinical development program, we have seen reports of TMA or thrombotic microangiography, TMA, which is essentially small clots in small vessels, and thrombotic events. And so for sure, there's, I think, reluctance to use APCC as a breakthrough as a bypassing agent for management of breakthrough bleeds. Having said that, though, there are a number of investigators out there looking to see how APCC might be used safely. So that remains an area under investigation, but at least in the clinical development program, we provided guidance around, using activated factor VII in preference over APCC for the management of breakthrough bleeding, and to keep the dosing to what investigators believe to be sort of the minimal effective dose that they need to control bleeding. And so with those mitigation plans in place, we didn't see continued problems. So that's one, but with any prophylactic therapy, there's really no prophylactic therapy out there that will prevent any and all bleeds for perpetuity. So there always will be a need to have a breakthrough bleeding management plan. And that should include, for patients with inhibitors, the use of agent as well as doses, and, really just communication with your hemophilia treatment centers and good coordination of care across the providers that you see. So
It's wonderful. Thank you. Well, that is just about all that we have for you today.
okay, great.
All right. Well, thank you again for taking the time to join us this afternoon. We appreciate your time and expertise. And I'd like to thank every single one of our viewers for joining us again this week, regardless of the platform that you joined on. Thank you for watching. Please note that this recorded webinar will be available on Friday, December 9th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week.